Okay.
Hi, can you hear me?
Hi, yes, I can.
Oh, good. Okay. All right. I've just luckily managed to get rid of my last patient to join you, so I feel a little bit harassed. Anyway, okay. So we just waited.
You made it.
Yeah.
Yes, Joy was here a few minutes ago. I think she's just switched off her video, but
Okay.
Dr. Joy, Dr. Esther, yes,
Hi,
there she is.
Oh, hi, Joy.
Hi, Linda.
Hi. Okay. All right. I'll just come off then. I'll be quiet now. Nice to see you all.
Okay, thank you so much for logging in our participants today to our first COVID-19 case management webinar series that we shall be hosting every Thursday afternoon at 2 p.m. Our topic for today is home isolation guidelines for COVID-19. As we continue with the COVID-19 response, there has been recommendation regarding home isolation for asymptomatic patients and those with mild symptoms. And today, our speaker, Dr. Joy Mugambi, who's a family physician from Baringo, shall be speaking regarding the home isolation guidelines for COVID-19. And we have Dr. Sarah Kiptines, who shall be also be bearing in on the conversation together with other panelists from Machakos. We have Dr. Tusi, who will also be joining us. My name is Dr. Elizabeth Gitau. I'm the CEO of Kenya Medical Association, and I'll be the moderator for this session. Our COVID-19 webinar series is supported by the Kenya COVID Fund and Equity Group Foundation, and is being taken care of by the various health professional association. I will mention Kenya Medical Association, National Nurses Association, Kenya Clinical Officers Association, Kenya Medical Practitioners Dentists Union, among other health professional associations. And we're very excited to have Dr. Mugambi start off this webinar series. So I will go ahead and let Dr. Mugambi present her slides. Dr. Mugambi, go ahead. Karibu sana.
Thank you very much, Liz. Okay. Thank you very much, Liz, and thanks to my panel who are on the back end. I'm Dr. Mugambi. I am a family physician and I'm currently working in Baringo County. I will be sharing more about the home-based care guideline, what is in it and what we can harness from it. And then we will have a discussion on the challenges that we have experienced in implementation of the home-based care guidelines and the opportunities that could be achieved with this home-based care guideline. So, COVID-19 clients. The following, I'll start off with a bit of the background in terms of SARS-CoV-2. It's a beta coronavirus like the SARS-2 and the MERS, a single-strand RNA virus with a lipoprotein coat, which is characterized by the beautiful spikes that are usually seen on the outside. And these spikes facilitate binding of the ACE2 receptors in the host. It's believed to have originated from bats and reached humans via pangolins or some other intermediate hosts. So this is still work in progress, and more is being researched in terms of the SARS-CoV-2. Though we know it's highly infectious and it is a respiratory virus, and thus the challenges have been there in terms of drafting out a guideline of home-based care, because you do not know how transmissible it will be within the home setup. And based on our home setup, not everyone has sufficient room and sufficient places to keep their clients within their homes. So the county has, the government has set out quite a number of initiatives to ensure that at least the 80%, when you look at this model, 5% of the patients with critical diagnosis are only 5%, and they need mechanical ventilation. So where are we putting our resources? As per Sharif Ismail et al., 5% are critically ill, whereas 80% have mild diagnosis with need at most of basic clinical care. And 15% are the ones who will have severe diagnosis and need just essential critical care or oxygen. So the question is, where do we base our resources? Do we just base them on mechanical ventilation and oxygen therapy, or can we harness on the power of the community and the families to be able to care for our patients with just basic clinical interventions at the very home stage? So how the isolation breaks the chain of transmission, and we look at this graphical illustration of how the infection comes in, the incubation period of 2 to 14 days, then symptoms set in, and the patient is symptomatic for a period which varies. Most places, the variation has reached almost up to 32 days to 35 days. And so within that time between the incubation period midway to the symptomatic phase, the patient is infectious and there is need for isolation. The pre-symptomatic phase, you may find the infectious period also, and yes, there is need for isolation at this point. So when we come to hierarchy of infection control measures, looking at the home-based care guideline, it eliminates and removes the hazard, from where many people are gathering, that's the hospital. It substitutes, it removes the hazard from, yes, the crowded areas. And then there is engineering control, where you are isolating people from the hazard by keeping them in their home states rather than moving them around. That process of moving them in a transportation system, then moving them within the facility, so many missed opportunities do occur. Then there is the administrative control, where we change the way people work. By taking health to the people in the community, we are changing how people work. Rather than having so many people, we are already having healthcare workers who are getting infected in facilities. If we change these administrative controls and take the health to the people, less people will be handling these people in the community, and less health workers are likely to get infected and make mistakes, where they are also handling essential services at the same time. Then protect the worker with PPE. This is key. As much as it's at the bottom of the pyramid, it's still as effective as we would want. But at the same time, remember, resources are not always available in large numbers. So we thus need also to ensure that these other steps are taken care of. That's the home-based care model, encompasses all these hierarchies of infection control measures, and we'll look at them deeper in terms of what has been outlined in the guidelines. So key points of the current guideline that has been provided by the government. Healthcare is an essential component in breaking the chain of transmission of COVID-19, and that is a key info that we need to carry and share with the community. So home care should meet the following in terms of what the government has laid down. It should be community acceptable. The community has to accept that they can take up home-based care, because we do not want people being stigmatized in the community or being rejected, or homes being burnt down, because this can easily happen. So there is need for lots of community engagement to ensure that they accept this model of home care. There is need for an appropriate caregiver who's available at home. You just don't want to leave someone in the house and have them locked up, and the next thing you're doing is breaking doors to find someone who died in the house and had no one to either cook for them, clean for them, or ensure that the symptoms are reported. So there should be resource for access to food and other necessities available. Definitely, if someone is in the middle of nowhere where probably they'll not be able to get food supplies to feed themselves, to be able to have soap to even clean up their homes, they definitely will leave the house to go and buy kanyama, as I heard from one of our care providers saying they found one isolate busy in the shopping areas going to buy meat because they felt a craving for meat, and they walked out of their houses. So the resources should be easily available. Currently, there is provision of the online shopping platform. Other than that, the communities can also be engaged to be able to supply people in their homesteads where there is no online supply of foodstuff. Then separate bedroom where the patient can recover without sharing immediate space with others. In the guideline, it still outlines, even if there is one room, you can easily separate the room, but keep a 1 meter distance from the contact and the client. So there is that provision also in the guideline. In the guideline, it stated no household member who are at increased risk of complications should be in that homestead. So when you go to evaluate the home, evaluate, are there people above the age of 65? Are there young children? Are there pregnant women? Are there people who have who are immune compromised? Do they have chronic heart diseases, lung diseases, or kidney conditions? Do assess and be able to see if there are other people who are at risk in that homestead. The individual room, it can either be a room which is en suite with a bathroom. Basically, this is an illustration, but we do have even huts which have a space that one individual is using on their own. It is up to the provider to be able to assess and see, is this room having adequate ventilation? Is this room having a good space where this person can be able to stay and be comfortable? Is it having a bathroom area where they can go without sharing with others? And if they are sharing, can it be cleaned and disinfected after every use? Then touch-free covered cans or dustbins in the toilet area, in the cubicle where this person is sleeping, if it is a room or a cube, and a doffing area, because healthcare workers will come there, they will doff, they will don. Even the provider, the caretaker who's in that home, will have an area where they need to dress up and remove those clothes once they are walking out of the room where they are caring for this individual. Use only essential furniture that are easy to clean. Do not have this velvet material that you will not be able to disinfect, material that when you spray the disinfectant, they'll get stained. A simple wooden or plastic chair would be the most ideal for these areas where you are quarantining. Should observe respiratory etiquette, which we'll talk about, proper hand washing, physical distancing, and frequent sanitation of the personal spaces. So when you're admitting, you should also factor this in your mind that yes, we are at the primary healthcare level, and this is what we can be able to provide as providers, and be able to ensure that these are met when you're dealing with your cases. Accomplish the COVID-19 case investigation form. There is a form that we fill out. You fill out the details of the client, you fill out the symptoms that they are reporting, and you report them. most of this has gone to an online platform which can be logged in and all the data entered in a simple manner, inclusive of the sample collection form and sample collection at the point when you're meeting this patient. Probably this patient has been seen well elsewhere and referred, or probably this is a contact who's coming from a homestead and you need to investigate them. Don't forget about the sample collection. Then secure an informed consent before admission. This is something that's missed out in most cases. Having an informed consent will also enable that you are not litigated, and also that the family and the community has accepted that this person can come back to the community. So ensure due care and compassion in breaking the presumptive diagnosis and management plan to these patients and the family representatives. Let's have respect of those individuals. This information should not be coming from a secondary or a tertiary source. It should be coming from you as a care provider who has already seen this patient. Remember to keep a chart of every patient that contains the following: the admission history, the monitoring sheet, and the medication administered, because probably this patient is being referred from a provider who's nearest to this client. So these documents may be going down to the dispensary or the health center. So keep these charts very well stored and be able to instruct the next healthcare provider on what they need to fill out. So after admission, you need to think about the PPE for home care isolation. And this is very key because you need to give these instructions to the care provider and to the health worker who will be going to those homesteads. Patients with respiratory symptoms, this is the patient that you are admitting, the one that you are sending in for isolation or quarantine. Any of the activities that they may be performing, they have to maintain physical distance of at least 1 meter. Provide a medical mask that's either a surgical or an N95 if they can tolerate, especially when sleeping, because yes, maybe they have other symptoms that do ensure that they cannot be able to use the mask. So ensure that you have provided a mask or train them to be able to stay in their rooms without having to leave the room. But when they leave the room, they use their medical mask. For the caregiver, entering the patient room but not providing direct care to them or assistance, provide an N95 mask. So that whenever they enter the room, maybe it's to pick a plate and they are not doing any change of clothes or handling any waste material from the client, then they can use an N95, quickly pick up the dishes and go to sterilize them, or provide beddings to the person who's in the room. For the caregiver who's providing direct care or when handling stool, urine, or waste from the COVID-19 patients, you need to provide them gloves or have them advise that they need to have enough gloves within the homestay, both reusable and the disposable one. Then the N95 must be, and if they are handling areas where they need, where activities may cause aerosolization, then a coverall and an apron if there is risk of splashes. For the healthcare worker who's visiting that homestead and providing direct care or assistance to a COVID-19 patient at home, it is complete emphasis that you should have an N95 mask, a coverall or a hazmat suit, and the coverall should be waterproof, and the hazmat suit should also be well secured in terms of that it's waterproof and you have a partner who can be able to help you don and doff whenever you go to the community. Then you need gloves whenever you visit these clients in their homes, and eye protection, either a face shield or goggles. So you need to advise your clients on how to wear a mask. We are seeing people who are having chin supports and who are having their noses exposed. But before that client leaves your office, ensure you have advised them on how to wear a mask, basically fitting properly from the nose all the way to the chin and secured at the nose and the loops on the ear, or if it is a tie back, ensure that you have shown them how to tie it properly behind the head, over the ears, and at the neck. Ensure that those instructions are well guided and provided. For respiratory etiquette, you need to advise the client and the care provider on wearing a surgical mask properly, when coughing or sneezing to cover the nose and the mouth with tissue or the crease of the elbow, because this patient probably will be transported from your facility to the homestead, and when in the homestead, they need to ensure they are covering their nose and disposing the tissue properly in a disposable proper bins which are covered. Then proper hand hygiene after the cough processes of sneezing. Then use of PPE for that care provider or that the person who's visiting the homestead. Ensure when entering the isolation room, you train them on how to use the coveralls and how to use the alcohol rub and hand washing. Ensure that you have trained them about collecting all items when needed and putting on the gown properly. And then ensure you have taught them on how to wear the mask and the N95 properly, because yes, we have seen people wearing the band at the bottom rather than at the top, and how to remove it properly without handling the front of the mask when they are removing the mask. Also, how to wear eye protection and how to disinfect it after use, and how to put on gloves and cover the gown cap. So these instructions should always follow the admission as you do your admissions in the hospital before the caregiver and the patient leave for home isolation. Then use of PPE. Before you leave the isolation, you need to also instruct them in terms of doffing and removing that gown and gloves, all the steps, peeling off of the gloves, rolling inside out, performing the hand hygiene. Remember, these are not health workers. They are community persons, and they need to learn this step by step and keep training them every time you visit that home and asking if they are still remembering these steps. Then how they should remove the goggles and how they should remove the mask and respirator. So on cleaning and disinfection, as per the guidelines, clean and disinfect patient surfaces, cutlery and equipment after contact with each patient, because I said patient, each patient, because it may not be just one person in that household. It could be one or two or three, but you need to ensure that each one of them is handled individually. Do not move from one room and go to clean the other person's room with the same gloves that you used in the other, because that would lead to contamination. So instruct the caregiver that each person will have their own equipment, their own cutlery, and each will be cleaned separately. Then always use gloves. For disposable gloves, they should be discarded after each cleaning. But if you're having reusable gloves, they should be dedicated for cleaning and disinfecting surfaces of COVID, and they should not be moved out of that room. If this is client A, and those are their reusable gloves, you clean them, you put them properly and within that room without moving them to the next room. Use regular household soap or detergent, then regular household disinfectant. This is Jik at 0.5 sodium hypochlorite or chlorine bleach of 3.8%, and dilute 1 cup of bleach to 6 cups of water. And this can be used now to disinfect the surfaces or the equipment that you are using when need be. Always wash hands immediately after gloves are removed. That is either the disposable gloves or the reusable gloves. Then store equipment used for cleaning and disinfection within the isolation area. Don't start moving them to the kitchen and moving them to the bathroom. Store them in each isolation room, depending on how many patients are in those rooms. So instruct the caregiver that these things are not to be moved out. On laundry, wear disposable gloves when handling the dirty laundry. Then discard after each use. You can alternatively use the reusable, as we have also instructed in terms of the equipment in the room. Clean the patient's clothes, bed linens, towel, using the regular laundry soap. Let them not get worried that they are going to be using any special soap, any disinfectant, but just basic laundry soap, even kipande soap, so long as it's soap and used properly, then it will be able to kill the viruses just as well as any other disinfectant would do. With water or with a washing machine, with water of a temperature of 60 to 90 degrees, but water generally, clean water, and ensure that these clothes are washed thoroughly. Then clean and disinfect cloth hampers. Include, for example, if you have put a bin somewhere for clothes to be disposed in, ensure that this is cleaned. And if there is a bag liner, ensure that you dispose or throw it away after each laundry has been removed from the room. If it is a bag liner that is easily cleanable, you can clean it along with the cloth and return it when returning it to the client. Then clean linen should be stored in a supply room outside of the isolation area. Do not return it to the clean linen to the isolation area, but keep it separately. Remember also to iron these clothes, because also heat is good and it helps to kill viruses and bacteria. Then for waste disposal, provide an untouched can, as we said earlier. Ensure that this infectious material and all healthcare waste is well disposed and disinfected before it is disposed. Ideally, our guideline indicates that there will be a community health worker who will be designated to pick this healthcare waste and dispose it within the healthcare facility that is nearest. It may be a challenge in some places where maybe the facility is far or the community health worker strategy has not been well implemented. So this is a key area that needs further discussion and deliberation on how these disposals can be best done even within the community. So all who handle healthcare waste should wear appropriate PPE. If you're sending that community health worker, please ensure that you have provided them with appropriate PPE, because these are community persons. Their education is basic and does not encompass health education, so you need to train them. Then provide hand hygiene before and after handling. Ensure that that community health worker who is going to collect that specimen can be able to ensure, the garbage can be able to clean up and be able to ensure that they have sanitized appropriately after handling the garbage. Use lined garbage bags. You need to provide also the advice in terms of what lining to use and how to use it appropriately. Some guidelines have indicated double lining of garbage bins. Next is monitoring of the patient. The patient should be instructed to self-monitor and record symptoms. This is that client you admitted from either the facility or the homestead after a call. Ensure that they are monitoring their 3 times a day, 8 a.m., 12 p.m., and 4 p.m., their temperature, their respiratory symptoms, and other body symptoms that they may experience within that time frame when they are in for home isolation. And they report to the healthcare worker if there is any symptom. Then the primary healthcare worker can provide treatment for mild symptoms such as antipyretics during the 12-hour shift that they are seeing these patients. Then report to the sub-county COVID-19 management teams once person with contact becomes symptomatic, and we'll talk about a person who's a contact and how to be able to define a contact in terms of management, the home-based care guideline management. Please advise the clients. There are those who are asthmatic. There are those who are using nebulizers at home or using their inhalers. Avoid nebulized medication that may generate aerosols. So in case a patient has symptoms that require nebulization, this is a patient who has respiratory symptoms and they require to call a health worker to be able to manage them. There are sample symptom monitoring forms that have been developed, and this can be a guide that can help you in terms of logging in symptoms. There is the Jitenge app, which is also available and can be used also for reporting of symptoms and reporting on a daily basis for those clients that are on home isolation. So for severe signs and symptoms, if it is an adolescent or an adult who develops one of these symptoms, respiratory rate of more than 30, severe respiratory distress, and a pulse ox of less than 93% on room air, for those who may afford to have a pulse oximeter at home, then they need to report. For a child with cough or difficulty in breathing, plus at least one of the following, they need to report to the health worker. Central cyanosis with SpO2 of less than 90%. So you need to talk to your caretakers who are at home on what is central cyanosis and how they can examine for that. Then severe respiratory distress like grunting with severe chest indrawing, you need to explain the caretaker and tell them if these are experienced, do call immediately and ensure that those call lines are available and can be responded to. Then presence of general danger signs, inability to breastfeed or drink. Those are common if a child is in respiratory distress, lethargy, unconsciousness, or convulsion. So take note, other symptoms of pneumonia may be present, which are the chest indrawing, the fast breathing, as defined by the pneumonia guidelines, and they should be taken note of, and these clients referred immediately. So for referrals and transfer, the client should have prior arrangements with the nearest health facility, and that is why we are emphasizing the nearest healthcare provider should be aware of any persons isolated within that area. Or an isolation hospital that caters for suspected or probable or confirmed cases of COVID-19. In an event of clinical deterioration, we advise that the confirmed cases and confirmed cases that a primary healthcare worker coordinates with the county management or the sub-county management and prepare for the referral and transportation mechanism to either a level 4, level 5, or a level 6 facility, depending on which facility is providing care within this region. So guidelines for patient admission, immediate referral, health worker should immediately refer the case and ensure that this patient is referred and received on the other side. So those in level 4 and level 5 need to be contacted early to be able to make event space and prepare for that client that is coming in. In case there is refusal for admission, which we have noted, and you will find patients who have decided to stay on home isolation will be very difficult in terms of going into hospital because of all the stigma issues, because of the issues surrounding COVID admissions and the fear in terms of the number of deaths that have happened when it comes to COVID. So as a manager or as a health worker who's dealing with these clients, do try and explain the rationale of admission and comfort this person for admission. If not, then be able to report and justify why this person has refused and report it to the next public health providers or the county management team. So referrals and transfer, it is key that in the guidelines, they state that at least provide ambulances. A basic life support ambulance is adequate enough to be able to move But if you have the advanced life support ambulances, that's a plus. The county government should have at least provide access to testing and retesting. And there should also be access to critical care services for these clients as early as possible. Those providing the ambulance services should have proper personal protection equipment. And since they will be monitoring this person as they transport them either from the household to the facility or to a higher facility as they move these clients. The driver should practice appropriate infection control. They need to have their jigs, their chlorine, their sanitizers, their masks appropriately worn, and avoid contact with the patient. They should consider, when dealing with these ambulances, consider having an impermeable, transparent barrier between the driver cockpit and the patient's main cabin so that also transmission is reduced. So we are ready to discharge these patients from quarantine. What steps do we take? From community isolation, you need to repeat the PCR testing. And once you have repeated this PCR testing, at least 2 consecutive negative tests 24 hours apart is preferred, or at least 1 negative test prior to discharge. That is if you're constrained in terms of availability to a PCR test, and they can be discharged. So some guidelines have stated that you can discharge when symptoms improve. Kenyan guideline does not have the symptom approach and has leaned towards the PCR testing of 2 consecutive negatives. So once you have done that, the patient needs to be cleared by the sub-county or the county health management team, and a discharge of these clients written clearly indicated that they have completed their isolation and all documentation well stored. On the other end, the county staff, they require to prepare whenever they are going to the community. This has been one of the biggest challenges. You find you're already in the community and you do not have some items that you require, and you have to stand there and wait for someone to go back to the facility, bring back this. So this is a document that can help you ensure that you have kept your stock ready and you have prepared your community visit bank with everything in readiness to have you visit the isolate wherever they are. Maybe it's an emergency in the middle of the night, so you need your eye protection, your face shield, your gloves, your hair cover, and all this equipment listed here, ticked out. Keep this stock listing somewhere and ensure that when you're going out in the community, your bag has everything so that you don't have to do things in a compromised manner and get infected. For that health worker, your PPE levels, at least this is how you need to ensure you're dressed up when you're going to that home state, so that you're safe, you're well protected, and you're not endangering your own life. Hand hygiene is a must. I'll re-emphasize this when it comes to health workers, because we can, for the client, and forget to emphasize hand hygiene. Ensure that before and after each direct contact with patient that you wash. Maybe you're visiting a home with 3 people who have been isolated. So after each patient, wash your hands. When you finish with the next client, wash your hands. And as you move on, ensure that you wash your hands. Immediately after removing gloves, remember to wash your hands or sanitize. Before handling any invasive device, ensure you wash your hands. And after handling that invasive device, wash your hands. After touching body fluids, ensure you do wash your hands also. And you remove your gloves, either with water or sanitizer. Remember, you may be in a place where you are handling a contaminated body or a body site. Remember to wash your hands before you move to a different body site on that patient. After you have done your specimen collection in the nose and the mouth, and probably you need to do an abdominal check, remember to wash your hands before you move on to the next point. After contact with inanimate objects, in the immediate vicinity of the patient, ensure that hand washing is done, and also after using the bathroom, ensure you do wash your hands. We need to emphasize safety and precautions for the health worker. So gaps that need to be customized in this guideline, we do note that the duty protocol are not clearly defined, but this is left also to the counties and the providers to be able to define the duty protocol. Ideally, 2 healthcare workers should be responding to these cases in their homes, because you do not want to send one healthcare worker who has to do donning and doffing alone, and then now they make mistakes in the process, or they end up finding that they cannot reach out to an equipment because they had already donned and they cannot sanitize or wash their hands. So there is need for at least 2 healthcare workers, either a nurse and a community health worker, or a clinical officer and a community health worker, or any healthcare provider that is available with a community health worker. Then avail human resource for 2 shifts. It may not be practical for that one staff who's working in the dispensary to handle everyone who's in a community, maybe of 100 or 100,000 people, but at least they need to avail 2 shifts for the 24 hours, because the client could change in the night. Avail PPE and train on proper PPE use, especially for the community health workers who are not trained healthcare workers, but they play a big role in terms of healthcare provision and contact with the families. One facility physician is essential, and they can work remotely because, yes, essential services also have to continue. Then staff symptoms are not well addressed in this guideline. Yes, we have some guidelines in terms of the contact, but also staff before and after they have handled this client, we need a check of the temperature before and after starting their duty, and maybe symptoms. Then accommodation and quarantine should be provided for healthcare staff. As far as they are offering services in the community, they could be going back to their homes, and they may be not comfortable going back to their homes after handling these cases of COVID in the community. Self-reporting of symptoms and IPC breach. There needs to be a clear guide on the guidelines in terms of self-reporting to the healthcare team lead. And health workers must follow a suspected case algorithm and contact management algorithm for IPC breach. They need to be able to get back, and this needs also to be included in your guidelines as you work on it. Remember, the healthcare providers at the dispensary and the health centers, who may be the ones providing care at the community level, may be the only healthcare providers in a wide area, and they cannot all be taken away in terms of quarantining or ensuring that they stay away from all other essential service provision. So the management needs to also think about healthcare and hospitalization coverage for essential services, since this staff may not be adequate at the community level. Mental health support for staff and the patients who are also in isolation need to be considered. So for other resources, you can check out the Ministry of Health website for the full home-based care guidelines. It's a 5-page guideline and very simple to go through. For other guidelines that you can refer to, there is the WHO guideline and also the CDC guideline. The images were from this website. Thank you. I'm now open to questions. Back to you, Liz. Dr. Liz? Sorry, Dr. Liz Gitau, we are back to you.
Thank you very much, Dr. Joy Mugambi, for the very great presentation. I will ask the participants to kindly put in their question on the Q&A area, even as I invite the various panelists to come on board and give in their word based on their home presentation. So without further ado, I will invite Dr. Linda Thorpe to make in a presentation or a comment based on the home isolation and her experience, and then we shall move on to the next panelist. Dr. Linda Thorpe, please.
Afternoon, thanks very much. I hope everybody can hear me and that my internet connection is okay. Thanks very much. Okay, thank you very much, Joy. That was a very good presentation and a little bit of food for thought for me. I'm in private practice, so it's very different. We don't have the same setup in regards to some of the resources. So, and a lot of other people may also be in private practice as well. So far, I've basically been supporting some of those patients who are on home care isolation. Majority are asymptomatic, well, all of them have been asymptomatic and picked up basically through screening because they're going to leave the country, or maybe because they've been a contact, but no, not because they're generally asymptomatic. Most of those that I felt have been symptomatic, they have basically gone on to have negative COVID tests. So one of the challenges that I have is how to support those people that I've got at home in view of the fact that they should be supported by the government in regards to, you know, the healthcare workers contacting them and supporting them in that respect. So quite a few of mine haven't actually had any contact from the MOH. So what I've done on a side is just to try and make sure that the protocols are all followed and that they follow the Jitenge system so that they monitor their symptoms. They are generally all in a position where they do have the right home-based care. So they do have separate bedrooms, separate toilets, and it's just trying to follow up with them that they feel supported. And if the MOH does contact them, that they have actually been following the right format. And then when it comes to testing negative, then generally, you know, at day 14, we get negative tests. Some of them have been getting 2 negatives, some of them have been getting 1 negative. So it's interesting to see that you can do either or. I suppose 2 negatives would be the best way to do it. And then with contacts at home, then we basically try to ensure that all the contacts at home also stay in quarantine, because obviously they're close contacts of the positive patient. Some of the challenges that I've had have been basically that patients who are positive, because they can afford to kind of run around and try and get more tests, then try and get tests done which are negative, so then can go and afford to maybe get 2 negative tests done consecutively, and then say that they're now not positive, which I find a little bit difficult, because if they're testing before they've done the the home isolation, then are they actually just getting 2 false negatives, which we know are more common than getting an actual positive test? So that, you know, those are kind of some of the challenges that I have, and obviously people don't want to believe that they're positive, so they then go on to blame some of the laboratories. I mean, I think that's been in the newspaper and things as well, as far as I can see, especially with Lancet, which is just unfortunate. So I think it also kind of makes it quite obvious that it's actually a community disease, this, and it's amongst us to try as doctors and also as patients, so to do the right thing, which unfortunately people, as we can see from how people behave, maybe the stigma maybe the fact that it's inconvenient to have to isolate, or they have to leave work, or if they're not at work, you know, is a big issue, because obviously people also see that they lose income, you know, if they were depending on going out. Anyway, so those are some of my thoughts and some of my experiences. I do a lot of WhatsApp with people that are at home. They just send me a WhatsApp message every day to say how they're doing and if there's any issues at all. So that's the kind of main communication that I get through the patients, and then just kind of follow them through till the 14 days, whether or not they've had any contact with the MOH. So anyway, thanks for listening. That was my experience.
Thank you so much, Dr. Thorpe. Dr. Sarah Kiptines, kindly give us your experience. Have you managed any patients who you've had to put on home isolation, and what guidelines did you put in place for you to be able to achieve this? And what have been maybe the wins, and what are the challenges that you have faced? Dr. Sarah?
Yes, thank you, Dr. Elizabeth. Maybe I'll just briefly summarize where I'm from. I'm Dr. Sarah Kiptines. I'm a final year family medicine resident working at Kijabe Hospital. Despite COVID-19 being an undesirable event, it does provide an excellent opportunity to strengthen our community-based primary healthcare, I think, in Kenya. And I'd like to trust that these systems shall continue to exist and even be strengthened after this pandemic begins to subside. So at Kijabe Hospital, we have currently only had one patient who ended up being referred home for home-based care. They were not within Kiambu County. We had to refer them out. Their home was in Kayole County. However, because of the process of the home assessment, the patient, despite having mild symptoms, had to be admitted and observed for at least 3 days before we got the green light from the Ministry of Health at Kayole County to say that the home was indeed acceptable and a safe place to discharge the patient to. So we haven't directly had one within our community who we've had to follow up with. But with this one patient, one of the things that I think is a reality is this issue of using the test-based strategy in terms of discharging patients from home isolation. I think that is one of the challenges that we will face, that not all counties and communities will have easy accessibility to testing. And I feel like even in Kijabe Hospital, we have had patients who, where we get positive tests even 7 to 8 days after the test was done, just because of delays on the lab end, due to understandable, overwhelming circumstances. So I think it would be important to still understand the other strategies, such as symptom-based strategy and time strategy for the different types of patients you face. So for example, for the person who's symptomatic, waiting for 72 hours of absolutely no symptoms and 14 days post the initial symptoms is a possibility. And for those who've been asymptomatic with a positive COVID test, you can use a time strategy, which is 14 days post 14 days post the positive test. Now, this will definitely need community acceptability, because patients will need to the community will need to accept that indeed there'll be those around them who do not get a confirmatory negative test. However, guidelines such as the CDC and WHO have actually said that symptom strategy and time strategy are acceptable modes. So if we strictly, I think the ideal, yes, is test-based strategy, but kwa ground vitu ni different. And that's a Kenyan statement for a very clear reason. And we cannot ignore the fact that there'll be those challenges, and we have had to implement that, where in some cases, a 14-day test, 2 consecutive tests, 24 hours apart, is not available. And that is what we've had to implement now, the symptom strategy for symptomatic patients or the time strategy for asymptomatic patients. One of the things, sorry, go ahead. May I go ahead? So
Yes,
one of the other things I have seen in the guideline is the specification of what PPEs are acceptable and unacceptable. In Dr. Joy's wonderful presentation, she mentioned the need for N95 masks for both caregiver and healthcare worker visiting. Again, the question and the challenge comes to this accessibility of N95 masks to all caregivers. As the numbers increase, my concern is that this may again be a very difficult PPE to, and the shield, it is ideal, it is the best thing to do, but again, if you look at other guidelines such as the WHO guideline, they've said that surgical masks would be okay for our caregivers. And the CDC, surprisingly to me, also said face cloth masks. I think those are probably not the ideal. I would at least push for surgical masks. And I think even in our setting, that is what we have accepted in some cases. Yes, push and aim for the best, which would in this case be the N95 mask. But the reality is at a point you may need to also accept surgical face masks for home-based care. I think those will be my statements for now.
Okay, thank you very much. Thank you very much, Dr. Sarah, for your experience in managing home isolation. Yes, definitely the guidelines per se have had a little bit of challenges, as you say, in terms of implementation by the healthcare workers. And I'm seeing certain questions on the Q&A part. Is one, how do you assess the risk factors among the household members in a scenario where members refuse to disclose their status, for example, HIV status? So I will let Dr. Joy Mugambi prepare to answer that. The other question is actually in terms of communication, and this is one of the challenges that will come in terms of home isolation. Dr. Mugambi has said in terms of the caregiver being able to take in various clinical parameters and possibly communicating that to the healthcare workers and the healthcare workers coming home. So one question is, do we have a communication system in place for the isolation patients with limited contacts of healthcare workers, like a working phone or contacts of healthcare workers they can call in case of change of conditions? And also the other thing regarding community health volunteers, are they availed with these PPEs, and who actually pays this CHV? Dr. Mugambi, possibly can come in there.
Okay, thank you very much. In terms of assessment of risk factors, the main thing is when you're doing your history taking and when you're preparing the admission of these clients, ask, advise, and ensure that you have explained them the repercussions of having a person with risk factors in the home state alongside a person with COVID in the home state. So long as you have done your part as a health worker, that you have explained and you have documented, then it still stands. It is the responsibility of the care provider and the client to disclose, and if they don't, the liability stands on them. So ensure that whenever you do this, documentation is very key, that you have explained and the client has understood and the consent has been signed. And in that consent, they have stated clearly in the consent, ensure when you're drafting your consent forms for clearance, that these consent forms have that clause that I do not have a person with risk in my home state. Let them speak, so that when they sue you and they take you to court, you have the consent with you and it is clearly stated and signed, and that you explain and you are clear of any liabilities that may occur. In terms of communication tools, in the community, yes, there is quite a number of challenges. There are those who don't have mobile phones. There are those who don't have a system to call back. Most counties and facilities have worked to have at least a phone that can be contacted or a person that can be reached. But looking at the envisioning of these guidelines was that using the community strategy and the fact that the community health worker has 10 households which can easily reach her within the community and she can communicate back. I think what is not in this guideline is what the remuneration, or probably what we do not see is how the community health worker will be remunerated in terms of the work that they are doing. Are they going to be facilitated in terms of telephone airtime, in terms of the time that they are spending in the community and calling back? So those things need to be envisioned even by the counties themselves as they implement the guidelines. So I think I also answered a question that was asked down there in terms of the community health workers remuneration. That is not clear, and probably that needs clear guidance in terms of how that will be done. Back to you, Lisa.
Thank you so much. I will be asking Dr. Tusi to give his thoughts on the question below. The question regarding as the cases increase, how practical will it be to actually assess each and every household in terms of acceptability for isolation? Dr. Tusi?
Okay, thank you, Liz, and thank you, Dr. Mugambi, for an excellent presentation. So to answer that question, I think it's an opportunity for that to happen, because I'll give you an example. For our first patients, actually family, to put on home-based isolation, there was this truck driver who tested positive at the hospital. And then we did contact tracing, and we found that all his family members except one child of 2.5 years turned positive. So that's a wife, 2 children, and a house help. So it became easier to keep them in the home environment. They were all asymptomatic, and according to the checklist, they all scored well, above 75 points. So they were eligible. So I'm looking at it as an easier way of flattening the curve and decongesting the facilities, because that's the only option then that's there. If we say we bring everyone to the hospital, then the next thing we'll be handling is our isolation wards are full and we have nowhere to take. So for me, I look at it as an opportunity to actually improve and ensure care and home-based care for those who have mild symptoms or no symptoms at all. So I think it's actually an advantage. And the earlier we familiarize ourselves and we ensure the communities and the general public are aware of this, we've seen it's improving compliance to the measures. And like somebody mentioned, it prepares the patient for integration back into the society and community upon recovery, because there is a lot of stigma still in the way we pick patients and put them in isolation facilities, so much that when we discharge them and they need to integrate to the community, the trauma is too much, and for them to even continue living, we leave them with some psychological scars. So I think it's something we need to embrace, and it's timely. And as the cases increase, it might be the only way to ensure that our facilities are not full. Of course, for those who qualify for the home-based care, which guidelines are clear as described by Dr. Mugambi. Thank you.
Thank you very much, Dr. Ntusi, for your input regarding your experience in managing patients with COVID for home isolation. I'm going to bring in Dr. Esther Mwinga. Having dealt with patients requiring palliative care, possibly you may have some insight to share, things that you can borrow from your experience in home management for patients needing palliative care, and what you can borrow and bring this to COVID. Dr. Esther.
Thank you, Dr. Liz, and thank you to all who've spoken before me. Maybe just to give a background of what palliative care actually is. This is a support that you're giving to a patient, not just the patient, but the patient and the family who is facing issues associated with life-threatening illnesses. So we are looking at three major domains: the physical aspect, the psychosocial, and then the spiritual aspects. So in terms of life-threatening illnesses, we know the range is big, starting from the patients who have a diagnosis of cancer, and now we are here at COVID-19, which is one of the life-threatening illnesses. So in terms of the care given for the patients who have these illnesses, we know it can be given in the home, it can be given in the facility. And most patients actually prefer care given where they are, because it's an environment they are used to, it's an environment they are comfortable in, and then I think just the homeliness of it makes life more bearable for them. So when we are looking at support of these patients now with COVID-19, we need to consider integration of palliative care services into their care. The reason I'm saying this is because palliative care, we say, focuses on the quality of life. These patients are facing a challenging diagnosis, not just for them, but also for their family. They are going to have various symptoms. So if the patient is a candidate for home-based care, based on the guidelines Dr. Mugambi has highlighted, we know the opportunities that 80% of these patients are asymptomatic. And if there's no contraindication for home-based care, there would be patients who can be followed up at home. And when we are looking at what services can be given to these patients, we are looking at the biggest challenge here is communication. So how do you talk to this patient? How do you break bad news to this patient? How do you communicate to this patient's family that this is the support you need to give the patient? This is the support as healthcare workers we are able to do. And so in line with the communication, we have a strength in terms of leveraging on technology, use of mobile phones, or use of even video calls if available, depending on where you are and your network. So a healthcare worker is able to see the patient in the home even without physically being there. And their patients, if able to, are able to monitor we mentioned the issues with saturation, so their temperature, their saturations, or their symptoms. In terms of giving holistic palliative care, we would need to consider support for issues like breathlessness, issues like agitation, issues like anxiety, whether they are in their homes or whether they are at home. So we have palliative care providers within 42 counties at the moment. So if a patient is in one of these facilities and they're able to be linked with a palliative care provider in that setting, it helps in terms of communication and support to the patient. So you're not just giving the follow-up for the patient, the physical follow-up, but they also need the psychosocial support in a holistic manner. Then, of course, at the end of the line, if the patient does not survive, it goes further to support grief and bereavement. So how are we supporting these people who are now left behind in case this patient complicated and they ended up passing on? So there's the support of the bereaved. And I know there was an issue being raised last week about a patient who died in Nairobi, then now had to be taken to their home county for burial. These people had not seen him for a long time. So how do they deal with grieving? Because the burial had to be done within a few hours as directed by the Ministry of Health. They were not able to touch, those customary things we have. So how do we support those who are left behind? How do we support their grief and bereavement? So just to emphasize, palliative care looks at, you're looking at curing sometimes, relieving often, but comforting at all times. So it doesn't matter the prognosis of the illness. This patient needs to be comforted together with their family, and so that they're able to have that zeal for the next day. Otherwise, once you kill their their joy for living, it already means that this patient may not fare well, just because of the fact that they have a life-threatening illness. Thanks, that's it for now. Back to you, Liz.
Thank you very much, Dr. Esther Mwinga, for your input there regarding experiences that you can borrow from palliative care. So I will focus to a question that has been asked by Geoffrey Omuse regarding the presentation being focused more on CHVs. How about family members offering care in the household? Do they need a 95 mask? I think Dr. Sarah Kiptines has mentioned regarding various recommendations from WHO as having recommended use of surgical masks. Is it compulsory to repeat the PCR testing after the 14 days? Or can we assume that one is negative and not infectious if symptom-free for a week? Dr. Joy Mugambi, do you want to answer that?
Yes, thank you.
Yeah.
Thank you, Liz, and thank you for that question. The key thing is, when I said the caregiver, not the community health worker in isolation. It is the caregiver that you are instructing as a healthcare provider when you're meeting with them in your facility. And these are the primary contacts that will handle this patient at all times. The community health worker is a link between the household and the healthcare provider, and they are not in isolation. They are working either with the nurse at the nearest facility or the clinical officer who's at the nearest facility, the healthcare provider who's at the nearest facility. So when you look at the guideline, basically what they state in terms of the community health worker, it's, yes, they are a link to collect also the disposable items and deliver them to the healthcare facility, and also link the patient with the healthcare facility. So the family is the key member that should be able to take care of these clients in all circumstances and be able to respond in terms of what the client needs or what is needed by the health worker in terms of communication.
Dr. Mugambi, there's a question regarding the Ditenge app. You had mentioned it during your presentation. Yes. Kindly expound on how exactly it is used to manage patients on home isolation.
The Ditenge app was initially an app that was developed that the truck drivers were using. I'm not the best fit in terms of explaining more about the Ditenge app, but it was an app that was used by the truck drivers initially and is now being converted so that it can be able to monitor and track people in their households who are in for home isolation, and they can be able to report back virtually to the providers. Each county can as well log on to the Ditenge app and be able to modify it for their facilities and their region to be able to be utilized by the people in the region rather than by just the whole country. And this is a good reporting system in terms of the symptoms, the temperature, virtually without having to go one-on-one with the client. So yes, the app is still yet to be modified and handed over to the home-based care system, but it has worked well with the truck drivers who are being monitored once they are tested and could be tracked easily using the Gitenge app. So it's easily downloadable. In case you have been put onto quarantine or isolation, you can use it also for your own self-monitoring.
So thank you very much, Dr. Joy Mugambi, for the answers, and even for our panelists. We thank you for giving us your time to actually do this first webinar on home isolation. Thank you, Dr. Sarah Kiptines, Dr. Linda Thorpe, and Dr. Esther Mwinga, Dr. Nthusi, for your for giving us your time to discuss this. So having had this conversation where Dr. Joy has shared the guidelines, I think possibly going forward next week, we might have a session where we are able to share the various experiences and the challenges that the various counties or the various isolation facilities have faced. Because as you notice in the comment section, we've had very practical questions in terms of how do you implement these guidelines? Some of these guidelines are very technical. How do you actually go about assessing someone's home? How do you go about, are you offering PPE to them, or are you just assessing that they actually have them? So I will let the panelists do one round of comments before I invite our Secretary General to possibly close the meeting. We'll start with Dr. Linda Thorpe. You're muted.
Sorry. Thanks very much for having me. I'm obviously one of the ones here that's in the private setup. So perhaps I've had a slightly different experience than, for instance, Joy's had. But I think there's quite a lot of good that's come out of this, and I think sharing experiences and challenges would probably help all of us to try and tackle this, because I think we're going to see more and more, home-based care coming up and in our different setups. And how do we make sure that as a community and, in the kind of public health setup, if you like, that we can, manage those cases properly, and that everybody tries to do the right thing in regards to their patient, and that there's an easy format to follow, because the guidelines are quite tricky to work out exactly, what should be done and where, especially when patients try and change the goalposts. And indeed, some of the doctors also try and change the goalposts, which makes it quite difficult. But anyway, so I'll look forward to next week. Thank you.
Yes, thank you very much for the opportunity. It was very nice hearing from Dr. Mugambi and hearing from the other panelists. I think one thing we need to remember is guidelines are not set, they're there to assist in how to start, where to start from. They're like a starting point. And therefore, recommendations and feedback from the participants and from all of us panelists to the necessary bodies is always open, and also to see how the community accepts it, and basically realize that it's not really set in stone. Yes, it is important to start at one point, but feedback is necessary, especially from the caregivers and the community health volunteers who will be on the ground. And I believe that those feedback channels will remain open. And as I said earlier, I trust that this is the beginning of community healthcare and primary healthcare starting and growing strong in Kenya. Asante sana.
Thank you so much. Dr. Nthusi?
Well, thank you everyone, and thank you Dr. Mugambi for an excellent presentation, and all the panelists for sharing your experiences. From the background of a family physician, I think like Dr. Sarah said, this is really setting foundations for home-based care, not just for COVID, but even for other conditions, because we have not had enough resources, both hospitals and human resource, to take care of patients with conditions like other illnesses. So this, if this, it's a demonstration that it's something that can work. It's something that we can all embrace in primary care and community-based care. And this will improve efficiency in managing patients, not just for COVID. I think for me, it's a continuation because I've been doing home-based care for these other conditions, and the patients really trust it, and they trust, they comply better when they are being managed in the setup of their own home and their families. So it is something which we need to support, and of course, following the laid down guidelines and using our experiences to revise them and edit them as appropriate, so that it's the best, the optimal use of the strategy. And thank you very much. And I long to take part and hear more in the next presentations. Thank you.
Thank you so much, Dr. Tusi, for that, and even for the emphasis that this might be just the time that we shall focus more on primary healthcare, and also to give power to patients regarding their management, so that it's a discussion between the physician and the patient as opposed to physician-driven. Dr. Aluoch has made a comment or a question here, which I would want Dr. Mugambi to weigh in on, even as she closes this, the scientific part of this session. In Kenyan situation, what is the risk of home care spread or infection to the uninfected, since indoor restriction is impossible?
Thank you very much, and thanks, Dr. Aluoch, for that comment, because yes, indoor restriction is really difficult, but if only we did consider each other and we cared about the next person that is with us, either in the community or within our setup, then we would be able to at least adhere to the restrictions that have been put. But also inclusive is the use of masks and ensuring that the basic hand hygiene, personal distancing is maintained in order to also contain the infection. Yes, we may not all adhere to rules, and this is common even in the workplaces that we are in, even in schools, institutions. Not everyone adheres to the rules set out, but it is our personal initiative to be able to protect ourselves and the next person that should be the thing that we as Kenyans now embed within ourselves. The highest possible ethics and standards should be within us. And this is the time when we are being tested. As I close, I would like to say this. COVID is here with us for a long time. And the resources we have in terms of healthcare are limited, constrained. And yes, we have a lot of difficulties on the ground, be it public, be it private. So as far as COVID is with us for a long time, we need to give communities ownership of their health. And with that, home-based care is a key system for us to give them ownership and to also partner with them in terms of provision of healthcare at the nearest point. This has been said by my colleague, Dr. Ndusi, and Dr. Sarah and Linda, and also Esther, who has been doing lots of home-based care for the cancer patients. Home is the best place. And where we do not have severe cases that require medical interventions, then being at home and eating well and having the psychosocial support of family is key. So the earlier we start implementation of home-based care and seeking community acceptability, then the more likely we are going to be successful in this venture of care of the COVID patient. Thank you, Elizabeth.
Thank you, Dr. Joy Mugambi, for the lovely presentation, and thank you once again to our speaker of the day, Dr. Joy, and also to our panelists. I will ask Dr. Simon Kigondi to share in a word from KMA and close the meeting.
Good afternoon. Dr. Kigondu is not going to be available because he is currently in theater.
Okay, thank you so much.
In the webinar, he is listening to you.
Appreciated. Our President-elect, Dr. Andrew Were, kindly take the floor if you're available. Okay, so I will take the liberty to inform the participants of this meeting is that one, for all the medical doctors who have joined this meeting, KMA shall be sharing your CPD attendance. For the other association, your associations will actually be sending your code for you to claim for CPD. I've already received one from the National Nurses Association of Kenya, so you should be receiving the same from us once the meeting is done. This meeting has been recorded and shall be available on our e-learning platform and shall be shared to other health professional associations so that you can refer to it when need basis, and also you can share to your colleagues who might not have been able to attend this meeting. Thank you so much for joining us and have a good afternoon. Bye-bye.